She's a graduate of the University of the West Indies, microbiology 2007. Her MBBS medical degree she attained at the University of the West Indies in 2002, and her Bachelor's of Science in Biology 1996 at the Florida International University with a graduating GPA of 3.5 out of 4. She bright. Yeah, she bright. A senior resident at the University of the West Indies, laboratory supervisor, laboratory consultant, medical doctor. She has worked as a medical officer at the Maxfield Avenue Health Center in 2004. Her professional affiliations includes Jamaica Medical Doctors Association, 2004 to present, Jamaica AIDS Support Committee, 1996 to present, the Caribbean Association of Clinical Microbiologists, 2006 current, Medical Association of Jamaica 2007, President, Student Program Committee, FIU Miami, and a member of the Association of Medical Consultants to present. Ladies and gentlemen, please put your hands together to welcome Karen Nicole Shaw. Thank you.
Okay, good afternoon, everyone. I would like to take this opportunity to thank the sponsors, Cari-Med and Abbott, for the chance to share just a few thoughts on a topic, as you see there, antimicrobial resistance, in terms of a renewed focus. And I think that the topic is timely. We've heard quite a bit, in terms of the arsenal from Ms. Chin, being put forward from Abbott, and I'm sure we'll hear later about certain things that are, happening with Cari-Med. I know that many of you are familiar with the topic of antimicrobial resistance, and I would consider this a moment to share, Now, the modern age of therapeutics was actually launched in the 1930s. I don't want anybody to put up their hand and say, I remember that, And it started off with the presentation of the sulfonamides. A little bit later, about 10 years, you had the introduction of the compound that we know as penicillin. What we've realized since that time period is that many antibiotics were developed. So there was a period where there was an antibiotic boom, so to speak. And of course, the drugs were important because it allowed for a dramatic decrease in not only the morbidity, but also the mortality rates, and that were associated with infectious diseases. I don't know, is that clear? Okay. I will walk you through some of it. What it says is that in the 1930s, you had the introduction of sulfonamides. Between 1940 and about 1970, we had a plethora of drugs, different classes being introduced. But between the 1990s, oh, sorry, my glasses are not working at that distance. Sorry. So after the 1970s to the 2000s, you realize that there's a huge gap. So nothing new has been in the pipeline for quite some time. But if you look at the bottom of this flowchart, what you realize is that while we have been doing good, the organisms to which we are creating these drugs have been busy. And therefore, they are working while we are sleeping. And there has been quite a bit of resistance that has been noted over the years. So since, as I said, during the 1990s, new antibiotic development took a sharp fall. And of course, during that time, bacterial resistance continued to increase. It took them less than 20 years in order for the bacteria to show signs of resistance. Now, when we talk about resistance, we know that antimicrobial resistance can either be naturally occurring, which means at a mutation point, or it can be an entire cassette, which means that there's a shift in the actual reading mechanism, so a whole new protein may be created. Or it can be acquired through a horizontal acquisition from a neighbor. It's like asking for a cup of sugar. We know that the resistance phenomenon is a natural and unstoppable concept. So we're not trying to, our focus with antimicrobial resistance is not to stop it, because we know we can't stop it. It's really to slow it down. And therefore, we have to do due diligence in looking at the antibiotics that we have available to us and preserve these items. So taking care, we use the term judicious prescribing practices. I know I'm preaching to the converted, but I will say it. Looking at our prescribing practices and the rules that come with antibiotics, we're hoping that we can actually slow down the concept of resistance. The development of resistance is generally slow. We've seen this. It occurs over a period of time in individual organisms, and it has it can either be reversible, which means that if you withdraw the precipitating factor, the driver, then you hope to slow the process down. It's not the case all the time, but we recognize that you can slow the process if you pull the drug. Some mutations may be reversible, which means once you expose the first time, the organism prefers this state of resistance and it remains, and therefore there's nothing we can do about it. We know that we can speed up the process, though, of utilizing antimicrobials in an inappropriate fashion. So we're using antibiotics to treat a variety of things. We use different combinations that may not necessarily be regulated. And we have a tendency to throw everything, including the kitchen sink, at an item. Those of you who are within the hospitals can just nod. Because you've seen it when you see the request for the antibiotics, you realize they're throwing everything. But that's not the only driver. Remember that it can develop in relation to poor compliance. I don't know how many of you remember the situations where red and black capsules are routinely available at the Crossroads Market for all persons. And it's not just this country alone. I can tell you that the Caribbean and, globally, and there are other mechanisms through which antibiotics can be had. In Haiti, they utilize the drug rifampin as an enhancer for sexual prowess. Yes, you're all mystified by that. I'm still wondering about how you explain the orange urine, but that's right. So they utilize the rifampin in another forum, and then, of course, what happens is that the treatment of TB becomes quite challenging, and they do have a high rate of multi-drug resistance TB in Haiti. This last one is, I guess you could say it's a bit unnerving, only for the mere fact that you can develop resistance through the use of antibiotics in other settings, such as in plant and animal health. So I don't know, how many persons have dogs? How many have cats? How many have cows? Okay, too far. So you realize that in the use of treating other entities, aside from humans, we utilize antibiotics in a different forum. Antibiotics can be used, fungicides in particular, have been used to spray crops. So we are exposed to this, in other forums. I've highlighted also that it can be used in the areas of food safety and food preparation, as well as in the environment, treating water sources, etc. So the problem looks like this. I don't know how many of you are familiar with the Iceberg Concept. Most of us will see this portion. So we see the superbugs, we see the newspapers, they sensationalize the development of these microorganisms. But then the truth is we should be more worried about the portion that you cannot see. I don't know if you've watched the Titanic. You realize that this is the portion that sinks the ship. And what it means is that there are layers, as we've highlighted, to the creation that we see above the water. Now, the Infectious Diseases Society of America has created what they consider to be a hit list. So there are certain organisms that I just want to highlight. On it, you have the methicillin-resistant Staphylococcus aureus. You have the vancomycin-resistant Enterococcus faecium, which is normally known as VRE. You have E. coli, Klebsiella, Pseudomonas, and Acinetobacter baumannii. Has anybody heard of these organisms? Because this is a routine hit list, you know. Do we have them in our setting? Do you think we are having a problem with them? All right, maybe I should take hands on that one. How many persons think we're having a problem with these organisms? Say yes, yes. Let me see the yes. Let me see the no's. All right, so I guess no's are shy. So we are having problems. We probably are not aware of the depth, but this is just a brief head count that has been provided from the National Surveillance Unit at the Ministry of Health. And that was for 2016. And while the number is small, what it's showing you is that we do have everything on that hit list and then some. Okay? So you see that we have the Acinetobacters, the E. coli's, the ESBL is the extended spectrum beta-lactamase producers, which can involve both E. coli, Klebsiella, Enterobacter, you name it. So realize that we are having a problem. Now, how far does the problem extend? When we look at some data regarding Acinetobacter baumannii, you realize that what is along this line is percentage resistance. On the x-axis is the antibiotics. You realize that when we look at the various classes in terms of the performance, we're seeing challenges regarding the cephalosporins. We're acknowledging that there are problems involving the quinolones. And of course, these levels are very high. Look at this, 80%. So that's Acinetobacter baumannii. It's very difficult to treat. And of course, the organism itself tends to like patients that are very, very dependent. So your patients in ICU are more prone to this organism. Let's look at Klebsiella. Is anybody disturbed by the chart? Because what it's saying here is that there's a lot of resistance in Klebsiella. Klebsiella and E. coli make up probably the most common ESBLs that we encounter in any secondary care facility. So you're seeing again a picture that I wouldn't say we're losing the war, but there is definitely a battle going on. E. coli, same picture. So we acknowledge that we have the items on the hit list, but what about some of the other items or organisms that we have in our midst? Remember now that TB is still available in our country. I don't want anybody to forget it. And when we talk about drug resistance, the WHO, which is the World Health Organization, estimates that in 2014, there are about 480,000 new cases of multi-drug resistant TB. So this is the estimate of how much in 2014. Jamaica has identified 2. Is that significant? Okay. And that was in 2010 and 2012. We've been very fortunate in that we have not identified an extensively resistant species to date. And we should continue to be vigilant because of the way we utilize quinolones in our setting. We utilize quinolones very heavily, and once you have resistance to quinolones in TB, it is classified as an extensively resistant drug-resistant TB. What about HIV? We know that the drug resistance is a problem. In 2010, there was an estimate of about 7% of all persons that are starting the antiretroviral therapy in developing countries had drug-resistant TB. And of course, in developed countries, they feel that the rates are a little bit higher. And some countries have recently reported levels as high as 15%. And this is starting the therapy, you know. So you have a big, big mountain to climb. And of course, the rates get higher when you are restarting. And that speaks to, you know, exposure of the drug leading to selection of resistant species, and of course, issues with compliance. So, if we are going to tackle this problem, we realize that we can't take the same approach. It used to be that human health would take the lead, and of course, that would involve a multidisciplinary team in itself, because the clinicians, the pharmacists, you know, the nursing, all of these persons would look at the end result, which is the patient. What has happened is that WHO has looked at the situation and they said that it is a global emergency, which means that they have recognized that the rates are spiraling out of control, and therefore it is not just a human issue anymore. And what they are recommending is that in order for us to address this threat, we are going to have to take a holistic approach, a multi-sector approach, which they have coined the term as a One Health approach. And what that is going to involve, what that will involve is that it's going to be a coming together of the various sectors. So they have said that resistant bacteria arising in humans and animals or the environment may spread readily. Once you have the selection of a resistant species, it will spread readily from one, not person to person, you know. They're more interested in the global spread. So you are opening up, you know, borders, and you have free travel and free trade. So therefore, resistance will spread from country to country. And they're looking at it as an epidemic. And they're saying that AMR, antimicrobial resistance, does not recognize any geographic or animal borders. So if the truth is there that we are a global village, then the global village is under siege. So the WHO has sought to partner with three main entities. We have the Food and Agricultural Organization, FAO, and of course the World Health Organization for Animal Health, which is the OIE. And what has happened with this group meeting is that they are looking at a collective action plan to address AMR. And the main focus of it is to ensure that antimicrobial agents continue to be effective and useful against the diseases that we're already treating, both in humans and animals. They're asking that you promote the prudent and responsible use of antimicrobial agents. And you're going to ensure that there is global access to medicines of good quality. And we already had some of that discussion earlier. So in a resolution that was passed in 2015, all the member states, of which Jamaica is a part of, have actually signed off on this agreement. So Jamaica has signed on to say, we acknowledge that AMR is a challenge, and we are willing to form this multi-sector group that will work on the One Health approach. So the actions that will be highlighted from this, we're looking to improve surveillance of antibiotic consumption and its resistance patterns. We want to increase awareness of AMR. We're going to be expanding the antibiotic stewardship programs. And may I say to all of my lovely pharmacists, we're looking for you to walk beside us and lead us in this regard, because some of the discussions, you may not have the interaction of the clinician, you may be the first line of defense. So regarding that stewardship, that guidance regarding prescribing, we're going to look to you. So the expanding of the antibiotic stewardship program, for which the primary focus is the management of the resistance. We're going to look to improve infection prevention and control. We're going to enhance the regulation of medicines and their management. We're going to continue to ensure that we vaccinate and immunize susceptible populations. And last but not least, we'll be strengthening the water and sanitation and hygiene provisions. So, in terms, I will give you the update regarding the national, this is not the new version. Please forgive the error. So in terms of the National Action Plan for Jamaica, I will say to you that it is in progress. We have 3 goals so far that we are working under. We want to increase awareness of AMR. As I said, we are the converted. So what has to happen is that there has to be a full-scale awareness campaign that is going to help the general population understand the importance of these drugs. And we are going to fully adopt the One Health approach, and we're working towards the prudent use of antimicrobials. We're going to ensure that there's continuity of these programs in order for it to be successful. And we're looking to strengthen the quality assurance programs. These are just a few of the areas that we plan to target. And we're hoping that it will make significant impact by addressing these issues as priorities. So, what is the take-home message for the pharmacy or the pharmacist? Well, I can say to you that the WHO has created something that is very interesting. There's a list, a critically important antimicrobial list. What they've done is actually ranked the antimicrobial agents according to their importance in human medicine, with the objective of helping us to prioritize which antimicrobials need to have some sort of containment strategy or intervention as soon as possible. The WHO has also sought to create a guidance document that would help in prescribing for food-producing animals and in terms of the antimicrobials. And the objective is to preserve their effectiveness and protect public health. So this is just a snippet of some of the drugs that were placed in that document, the critically important antimicrobials. I haven't listed all of them. I've decided to show the ones that are readily available to us now. And I will highlight to you that the ones in yellow are the ones that have received the highest priority. Do you realize that those are the ones that we use fairly routinely? Okay? So, we have a lot of work to do. Another entity for pharmacy, standardization of reporting of antimicrobial consumption. The WHO is looking at circulating a methodology for monitoring antibiotic consumption. And I understand that the training is ongoing. They have accomplished, this process in 35 countries, and of course there are more planned for years. The WHO, the last WHO model list of essential medicines. So in this, the antibiotic chapter that was designed to talk about the essential medicines, they have sought to update it because there was a huge oversight in that the medications for TB were not included. And there are also some pediatric preparations that were not included as well. And they will be addressing these items. And these pediatric preparations speak to the management of things like sepsis and blood infections, various blood infections. So, lastly, they have an appropriate use of antibiotics being supported by ongoing programs in medicine, in the management in many, many countries. The WHO has a priority list of antibiotic-resistant pathogens. Now, this is a little bit different than the ISDA, And what they have done is that they've listed the priority antibiotic resistant bacterial pathogens. And what they're doing is highlighting those organisms that they would like the various entities to start research in the creation of new antibiotics. As you realize, the pipeline for antibiotic creation has been very dry. And therefore, this is significant because there may be hope on the horizon. Of course, with anything new, it comes also regulation and on, prescribing practices. But it shows that they're going to now inspire research, in the development of new drugs. So I would summarize to say that we are acknowledging that the modern age of therapeutics, it was a good golden age. I can say that, okay? Started in the 30s, but as with anything that is new, it becomes a little dull, tarnished, overused, And since the 1990s, we really have not had anything new. And while there hasn't been anything produced, we are acknowledging to a level that the bacterial resistance continues to increase. So, having said that, we are going to address this threat, and how we're going to do it, we're looking for a holistic approach. As I said, it's going to be a multi-sector, multidiscipline team. It is going to take every one of you and me. And therefore, Jamaica has signed off on this agreement, and we will be going forward. And the approach is not only geared towards health, but it's looking at human health, but it is looking at plant, animal, food safety, and the environment. And what they're going to do is they're going to ensure that antimicrobial agents continue to be effective and useful in curing diseases in both humans and animals. And that's where, thank you so much.
Thank you, Dr. Shaw. So we'll leave the floor open for 2 questions. I'm so sorry, I know you guys want to ask 10 and 15 and so on, but if you all don't want to go home, we can do 20. So I'm suggesting 2. Can we have a vote, 2 or 3? 2. Yes, man, I don't want to go home too. All right, so 2. Dr. Shaw, you need to come back here because you've got 1 taker so far. Oh yeah, the spotlight, the thing.
Thank you so much, Dr. Shaw. Very informative presentation. We appreciate that. I remember maybe 3 years ago, I was sitting in this very room when we had this discussion about bacterial resistance. At that time, I was working at an institution where that was becoming a significant problem. And even with the pharmacy department, having an intervention, seeking out physicians and having a dialogue with them, nothing changed. Yes. We were assured at that meeting that there was a national program going on that would design an antimicrobial stewardship program and that there would be some protocol of use. Yes. We haven't heard anything. So, as a physician said to me once, when we challenged the use of the fluoroquinolone, he said, hey, I go for the big guns because I'm guaranteed that it will work. Yes. And so we're coming up against situations where the physician says, this is what I want for my patient, this is what I want to use, without the support of the microbiologist or a system in place. What can we do?
Yes, well, thank you for the comment and the question. I would say to you, I am aware of, your current situation. It is a bit challenging when you're placed between, as they call the proverbial rock and the hard place. In terms of the prescribing, if you want to call it policy, I can say to you that yes, that is an item that is long overdue. It is one of the priorities of the technical working group that is now working on the National Action Plan. We are going to be looking at that document with some expediency because we realize that there are so many challenges regarding antibiotic combinations, if you want to call it the broad spectrum versus narrow spectrum. All of these items have to be addressed. So I can't give you a timeline on that document, but I can definitely say to you that it is a priority, and it remains a priority. In terms of some of the other aspects, the antibiotic stewardship, as I said, the challenge with that, we are asking the infection control. What we're planning to do is to try and marry the two conversations. Right. We're asking the Infection Control Committee to assume some responsibility in those facilities that don't have access to a microbiologist. Okay. And we're asking that those committees, and that's both in secondary care, if you want to call it tertiary care, or specialist facilities, as well as in primary care. So we're looking to develop these entities across the health sector. And what will happen with those infection control committees, they will also serve to fortify the discussion of the antibiotic stewardship. So there will be guidance from both the infection control committee regarding patterns of resistance and such, and where applicable, they will ask for referrals if it is to get guidance, have the input of the microbiologist to help bolster the discussion about the antibiotic choices. When you put that now in the framework of what we talked about originally, you see the need for the antibiotic prescribing policy.
Right.
Because if you don't have the framework, the legal framework, it's very hard to get a behavior change. So we have many things to work on, and I'm hoping that we can continue to partner and work together to, eventually overcome that challenge. But it is a real problem, so I'm acknowledging that, yes.
Okay. Is there any practical suggestion that as pharmacists we could employ to assist this process, at least until we have some guidance
of the
development of
that challenge with prescribing or issuing the drug based on the clinician's request?
Right. What
yes,
can we do?
well, I mean, you can give guidance, of course, communication, as we've highlighted, you could speak to the clinician regarding it. I know that sometimes that may not change, their immediate prescribing practice. You can seek guidance, as we said, if you happen to have access, you ask them if there's any guidance that can be had through testing. You could ask them about if any samples have been taken to give, because when a sample is taken, the evidence is actually in the result. So it will help bolster your argument in the sense that you can say, was there any testing done, if that can help guide the discussion and lead. Other than that, I mean, you may have to issue with the recommendations that, you could consider de-escalation as well. Yes, you may start broad, but could you consider a change once there has been maybe some guidance from the laboratory or the microbiologist?
Okay, thank you, Dr. Shaw.
Sure. Is there a second person? Okay. I'm not sure. Can't see.
Are you going to be asking a question, or are you just running to the place? Looks like she's going to the place. All right, so thank you, ladies and gentlemen. Sorry? Dr. Bent? Mm-hmm. Mm-hmm.
By the time the report comes back, the person might have left us.
True. True.
What I try to do is something like
Yes. Right. Okay, I'm going to let Dr. Shaw answer that.
Because you could have just nodded, yes. Okay. Dr. Bent, you're quite right. I mean, we're not going to be changing how we, all right, how can I put this? We don't want to change the way we operate, you know. What we want to do is be more, if you want to say wise in our decisions. Yeah, well, judicious, yes, but wise in our decisions. So if you look at the problem at hand, we have many. There are many gaps. Okay, you talk about the patient disappearing, that is a true gap. You may have one shot at treating something quite significant, and therefore you have to make a decision where you prescribe something very broad because you are unsure. Until you get back your microbe, then you will not be able to do anything but choose a broad spectrum antibiotic or whatever it is at the time. But what I'm saying to you, it falls on us at the end of the day, and that's why I said be wise. One of the gaps, as you mentioned, is that the laboratory takes a little bit of time to provide a result. We're acknowledging that. And therefore, in this whole discussion, what has to happen is that the various gaps have to be closed in order for the process to run smoothly and there be some sort of, if you want to call it, trust. We're going to build back that trust that if it is that we choose an antibiotic of this nature, we plan to review the patient in some forum to see how they're progressing and make a choice to pull back. Do you understand? If it is that you write for a certain amount of time, please see the patient again. Please take the sample. Trust the system. You understand? Trust the results. You have to trust the system. So, I'm not saying that we are going to change the way we work. We're just going to be smarter about how we're doing the work. Okay? Dr. Bent?
Yes.
Okay. Yes.
I remember I think the case you once cannot hear.
Okay. She needs a press the button. See if it will work for you there. Red button. No, the other one. Yes. No, red. Yes, that one. No, not working. Okay. All right. Yes.
She has an infection that she can't resolve down here. Her sister nurse in Canada.
Sure.
And so she wants me to apply. But she had a urinary tract infection.
Okay.
We sent her out in a culture and I gave her 1 gram of amoxicillin 3 times a day.
Yes.
For 3 days.
Okay.
Waiting for the report to come back.
Mm-hmm.
When she came back, she was totally different. She felt better. What the report said, this bug is not sensitive to penicillin. She said, Dr. Don't change it because I never feel like this would for such a
Okay.
long time.
All right.
So let's finish it.
Yes.
And I said, okay, what will you
Sure.
do at the end of the 10 days is do over the country.
Definite. Okay, so for the persons, I'll just tell you what Dr. Ben said. She had a case where a young lady had a challenge in terms of an infection, a UTI. She was very ill. She prescribed an antibiotic, amoxil, 1 gram, TDS. You said TDS? TDS. And of course, she took the culture. The culture suggested that it was positive, confirmed her thoughts regarding the UTI. When the patient returned for her second visit, she was noticeably well. And of course, you're caught in that little quandary where you have to change the antibiotics based on the culture because the culture said it was not sensitive to amoxil. Or do you proceed to treat the patient? All right. Should I ask anyone's thoughts on that before I answer? Because, you know, there is a rule within microbe, you know, believe you me. While I work in the laboratory, the rule goes like this. We don't treat results. We treat patients. So the thing is that you have there will always be a dilemma. But she did the right thing. She made sure that she repeated the culture at the end of the course of antibiotics to see if the organism has been cleared. So you see, it lends itself to some of the thoughts that I'm saying. We have to be smarter. We can't assume things someone else will catch. No, you have to assume responsibility for whatever it is. And therefore you must You must have that conversation with the clinician regarding the choices. That is within your right to have that conversation. Advise them of the antibiotic choices. Advise them if they proceed what can also happen. Talk about the various interactions and the possibility of resistance developing. Come back and review the patient, for those of you who have access to the system like that. You must encourage, the physicians must do due diligence and review the patients once they put them on antibiotics. They must take a sample, and we are looking to have these things become the norm. It's the only way going forward. All right? Thanks, Dr. Ben. Everybody else? Good? Thank you.
Thank you very much, Dr. Shaw and audience. Okay, so a quick announcement. The Abbott survey, you guys have it. It's supposed to be a hard copy. Ensure that you fill it out, and you can just leave it by the Abbott booth or by the customer service area on the outside. Okay? At this point, you're going to have Miss Mary Harrison make a presentation to Dr. Shaw.
Good afternoon, everyone. Dr. Shaw, on behalf of the organizers and all the attendees here today, I just want to tell you thank you so much for sharing with us as we continue and further the discussion on bacterial resistance. Thank you.
Thank you.